Welcome back. In this talk, we're going to discuss surgical infections. We'll start off by describing how infections occur, and then we'll move on to talk about many of the common pathogens that are seen on a surgical service. We'll finish up by talking in some detail about two specific types of surgical infections, namely wound infections and central line infections. For a patient to develop an infection, multiple factors must be present. First of all, the patient must encounter an organism that is capable of causing an infection. Usually this organism will possess one or more specific virulence factors. Besides exposure to a pathogenic organism, there must also be some breach in the patient's local or systemic defense mechanisms. Lastly, local environmental factors can greatly increase the risk of infection as well. Infection is a complicated balance between intrinsic microbial pathogenicity and intact host defenses. Some bacteria have evolved special characteristics that make them capable of causing human disease. Some bacteria produce exotoxins that they secrete into the local environment. These exotoxins cause damage by entering host cells and disrupting a normal cellular function. Clostridium tetani produces a potent neurotoxin. Clostridium botulinum produces a neuromuscular toxin. Clostridium difficile produces toxin A and toxin B, which lead to the characteristic secretory diarrhea. Staph aureus can cause toxic shock syndrome, and group A streptococci secrete potent hemolysins and collagenases, which are important in necrotizing soft tissue infections. Endotoxin is an intrinsic lipopolysaccharide cell wall component of gram-negative bacteria. Endotoxin is released into the host circulation upon bacterial death or lysis. Lipid A appears to be the toxic portion of endotoxin, and experimentally it is capable of causing all the hallmarks of gram-negative sepsis. Endotoxin is able to activate both the intrinsic and extrinsic coagulation cascades, as well as the alternative pathway of the complement cascade. In addition, endotoxin activates macrophages, which leads to the secretion of numerous cytokines, including interleukin-1, tumor necrosis factor, and interleukin-6. Besides exotoxins and endotoxins, there are many other known virulence factors. Pneumococcus has a thick capsule that surrounds its cell wall, and this makes it resistant to phagocytosis. Staph epidermidis secretes a slime that facilitates its adherence to foreign surfaces like intravascular catheters, heart valves, and orthopedic implants. Other bacteria are capable of producing enzymes that inhibit phagocytosis. Antibiotic resistance can be considered a type of virulence factor. Antibiotics target a structural or metabolic vulnerability in bacteria, with cell wall synthesis and protein synthesis being the most common targets. Antibiotic resistance occurs primarily through plasmid transmission, which is the horizontal transmission of genetic material between non-related bacteria or even between bacteria of different species. We're all familiar with methicillin-resistant staph and vancomycin-resistant Enterococcus, but the development of multi-drug-resistant gram-negative rods is becoming a huge clinical problem, since it affects the most common pathogens like E. coli and Klebsiella. We've discussed how microbes can potentially cause disease in humans. Now let's discuss how the host is able to defend itself. There are multiple possible portals of entry for a pathogen, and local defenses are designed to prevent a breach of one of these portals. If a microbe does gain access, then the systemic defense network should kick in to save the day. Perhaps the most obvious way a pathogen can gain access to a human host is through a breach in the skin. The skin, however, is well designed to ward off invaders. The principal defense mechanisms of the skin are dryness and desquamation. Most areas of the skin are dry, and the only areas where bacteria are present in large numbers are the moist intertriginous areas like the axilla and the groin. In addition, the outer keratin layer is constantly being shed, and this prevents bacteria from gaining any sufficient foothold. Lastly, sebaceous glands secrete a lipid that's inhibitory to most bacteria. Of course, surgical patients often have numerous breaches in their skin from our incisions, central lines, and drains, and so this makes them much more prone to infection. The respiratory tract is another possible portal of entry for microbes, but this area is well defended as well. The nares are capable of filtering out large particles, and anything that gets past the nares can get trapped in the mucus layers in the trachea and bronchi. The mucus contains IgA and lysozyme, and the cilia move the mucus towards the mouth where it can be expelled. If any pathogen does make it down into the alveoli, the pulmonary macrophages will be there to greet them. In surgery, our use of NG tubes, and especially endotracheal tubes, bypasses these defense mechanisms. It should go without saying that we should remove these tubes at the first opportunity. The gut is another possible pathogen portal of entry. The stomach is normally very acidic, which kills off any ingested pathogens. However, many surgical patients in the post-op period are started on acid-reducing drugs to minimize stress ulceration and reflux. This can have the side effect of leading to bacterial overgrowth and increased risk of pneumonia. The bacterial content of the small bowel is typically very low, and frequent peristalsis prevents bacteria from gaining any type of foothold. However, a prolonged postoperative ileus can lead to bacterial overgrowth and potential translocation. The colon is a low-oxygen, low-motility environment that's just loaded with bacteria. It's estimated that there are 10 to the 12th bacteria for every gram of feces. The great majority of colonic bacteria are obligate anaerobes, and the most common species are Bacteroides, Streptococci, and Clostridia. Why the human colon evolved to contain so many bacteria is unclear, but it's also true that these bacteria serve many important functions. They're important in vitamin K synthesis and breakdown of dietary carcinogens. It's also likely that these large numbers prevent the growth of any pathogenic species. In surgery, we use and likely overuse broad-spectrum antibiotics, and this greatly reduces the normal colonic flora. This allows for the emergence of pathogenic species like Clostridia difficile. The urinary tract is generally protected from infection by the frequent periodic flushing of urine via urination. In addition, urine is bacteriostatic by virtue of its high urea content, high osmolarity, and low pH. In general, females are more at risk for UTIs than males because of their shorter urethra. In the surgical population, our patients are at risk for UTIs because we often use a Foley catheter. In general, we should get this catheter out as soon as possible, and ideally within 48 hours. Once the local defenses have been breached, the systemic immune system takes over. Neutrophils are part of the innate immune system, and they are the first responders on the scene. They recognize and phagocytize foreign cells, and they do this by recognizing opsonins, which are extracellular proteins that bind to foreign cells. Macrophages are also a critical part of the innate immune system, and they're extremely versatile. They function as antigen-presenting cells, phagocytic cells, and they produce innumerable cytokines, which will be responsible for further coordinating the immune response. The complement system is an antibody-mediated system, and this leads to the development of the membrane attack complex on the foreign cell. Local wound environmental factors are also critical to the development of a surgical infection. In general, 10 to the 5th bacteria per gram of tissue is the inoculum necessary to cause a wound infection. However, more virulent species, in particular Clostridial species, require fewer numbers than this. Adjuvant factors are local wound factors that amplify bacterial resistance or reduced host responsiveness. Some particularly potent adjuvant factors include blood, foreign bodies like suture material or prosthetic grafts, and necrotic tissue. The presence of any of these greatly reduces the number of bacteria necessary to cause an infection and also greatly reduce the ability of the host to successfully respond. With that brief review of the various determinants of surgical infections, let's now review the most common surgical pathogens. Staph aureus is the most common isolate from wound infections after clean procedures. This bacteria is found in the nares and moist skin areas in about 40% of people. The presence of suture material decreases by 500 times the number of Staph aureus required to cause an infection. In the hospitalized setting, most strains are methicillin resistant, which means that IV vancomycin is the first-line treatment. Linezolid is a useful oral agent that is often prescribed for outpatients or for patients who have a contraindication to vancomycin. Staph epidermidis is part of the normal skin flora. It is generally considered a non-virulent bacteria since it rarely causes wound infections. However, some strains are capable of producing a slime, which allows it to adhere to central lines, heart valves, and prosthetic joints. When these devices become infected with Staph epidermidis, antibiotic treatment is rarely successful, and usually these devices will need to be removed. Streptococci cause many different types of infections seen on a surgical service. Group A strep consists of a single organism, Strep pyogenes, or sometimes called beta hemolytic strep. This organism is responsible for severe necrotizing soft tissue infections as well as erysipelas, which is a combination of cellulitis and lymphangitis. This organism causes such severe infections because it produces multiple exotoxins. A few of these include hyaluronidase and streptokinase, which facilitate the spread of infection along tissue planes. Group B strep is seen on the pediatric and pediatric surgery services. This organism resides in the female genital tract and is responsible for neonatal sepsis and neonatal meningitis. Strep pneumoniae, or Pneumococcus, is an encapsulated bacteria that's responsible for pneumococcal pneumonia. This infection can occur in both a community setting as well as a hospital setting. For surgeons, pneumococcus is important because it's responsible for overwhelming post-splenectomy sepsis. And so any patient who's scheduled for an elective splenectomy should get the pneumococcal vaccine 2 to 4 weeks before their procedure. If they've had an emergency splenectomy, which of course is far more common, they should get their vaccine prior to discharge. The vaccine, however, is only about 65 to 70% effective. This lack of efficacy is because there are many different strains of pneumococcus, and the common vaccines only cover about 20 of these strains. Enterococcus is part of the normal flora found in the GI tract and female genital tract. When it is isolated from intra-abdominal or pelvic abscesses, it is usually part of a polymicrobial process that consists of gram-negative rods and anaerobes also. Enterococcus is responsible for many UTIs and some cases of endocarditis as well. The big challenge in treating enterococcal infections is that it's now resistant to many antibiotics, including vancomycin. Vancomycin-resistant strains will need to be treated with linezolid, daptomycin, or tigecycline. Neisseria consists of 2 pathogenic species, meningococcus and gonococcus. Gonococcal infection is a sexually transmitted disease that, when it spreads beyond the cervix into the fallopian tubes, is known as pelvic inflammatory disease, or PID. PID can be responsible for pelvic abscesses and is occasionally mistaken for appendicitis. If there's more generalized spread of the gonococcal infection throughout the abdomen, this can result in perihepatitis, otherwise known as Fitzhugh-Curtis syndrome. We will sometimes see evidence of this during laparoscopy or laparotomy when we notice filmy adhesions from the liver to the abdominal wall. Gram-negative rods are facultative aerobes that are found throughout the entire GI tract. Since they contain endotoxin, they are a clinically important cause of septic shock. E. coli is by far the most common isolate found in biliary and intra-abdominal infections, whereas Klebsiella is a common cause of hospital-acquired pneumonia. Gram-negative infections are becoming more difficult to treat because of the emergence of multi-drug resistant organisms. Pseudomonas species are obligate aerobes, and they can survive in water almost without any other nutrients. For this reason, Pseudomonas is most commonly found in ICUs, where it contaminates ventilator circuits. Pseudomonas can also be spread by ICU personnel from patient to patient. Normally, our host defenses are highly effective against Pseudomonas colonization and infection. And so the patients who do develop Pseudomonas infections are usually very debilitated and are on long-term broad-spectrum antibiotics. In fact, Pseudomonas aeruginosa is the leading cause of death from nosocomial infections in the ICU. Pseudomonas infections are very difficult to treat, and they usually require at least 2 antibiotics. A common regimen will be a penicillin or cephalosporin along with an aminoglycoside. Anaerobic bacteria require a low oxygen environment. They are usually found in the mouth and most especially in the colon. Most anaerobic infections are mixed infections, with aerobic bacteria being present as well. Anaerobes are very difficult to culture, and so empiric treatment usually is started when we clinically suspect an anaerobic infection. Some predisposing conditions for anaerobic infections include poor vascular supply, the presence of tissue necrosis, and of course, any kind of colon perforation or anastomotic leak. Bacteroides species in general are low virulence organisms, and they're found in enormous numbers throughout the colon. They do contain an endotoxin, but this is of poor biologic activity and is almost never the source of septic shock. Bacteroides species are very slow to grow in culture, and so we treat empirically whenever we have cases of complicated intra-abdominal sepsis. Clostridia are gram-positive spore-forming rods that are by far the most virulent anaerobic species. All of these bacteria are found in soil, but several of them are normal flora in the colon. Clostridium tetani infections occur in non-immunized or partially immunized individuals with dirty, contaminated wounds. This bacteria secretes a very potent exotoxin that causes muscle spasms. Any patient in the emergency room with a traumatic wound should be queried about their immunization status and a booster shot given if necessary. Established tetanus infections are treated with penicillin, and immune globulin can also be given to neutralize circulating exotoxin. Clostridium perfringens is a gas-forming organism that is responsible for highly lethal necrotizing soft tissue infections. Antibiotic treatment of these infections is insufficient. The only thing that will save a patient's life is radical surgical debridement. Clostridium difficile infections are a source of morbidity and occasional mortality on a surgical service. This bacteria is normally found in the colon in low numbers, but in patients who have been on broad-spectrum antibiotics, the competing flora can be killed off, leaving the C. difficile to grow relatively unchecked. C. difficile secretes two exotoxins, A and B, which damage the colonic mucosa and lead to the clinical picture of diarrhea and pseudomembrane formation. The treatment of an established C. difficile infection is oral vancomycin or Flagyl, but of course, the best approach would be prevention, and all patients on broad-spectrum antibiotics should have them discontinued at the first opportunity. On a surgical service, fungal infections are caused by the opportunistic fungi, with Candida being the most common pathogen by far. Candida is part of our normal flora and is found in the mouth, upper airway, and GI tract. Candida overgrowth occurs when competing bacteria are eliminated by broad-spectrum antibiotic use. Additional risk factors for Candida infection include malignancy, immunosuppression, steroids, diabetes, and hyperalimentation. Antibiotics active against Candida include micafungin, fluconazole, and amphotericin B. If the patient has a candidal infection of an implantable device like a central line, the line will have to be removed. Aspergillus and Mucormycosis fungal infections are far less commonly seen than Candida infections. Aspergillus can affect the ear, sinuses, orbit, lung, and brain. Mucormycosis infections can develop in uncontrolled diabetics, as well as burn patients and overall immunosuppressed patients. These infections typically begin in the nose and spread contiguously to the palate, orbit, eye, and brain. These are highly lethal infections, and the treatment is drastic, consisting of radical debridement and amphotericin B. I'd like to mention a few words about hepatitis and HIV infections. Historically, patients were at risk of these infections from exposure to infected blood transfusions. Fortunately, this problem has been largely eliminated by effective blood bank tests that screen for these pathogens. Healthcare workers, however, are also at risk for these diseases from exposure to an infected patient's blood and body fluids. And so all of us need to know what precautions to take so we can safely do our jobs. Hepatitis B is a DNA virus that is now a very rare cause of post-transfusion hepatitis. If an unvaccinated healthcare worker gets a needle stick from a hepatitis B positive patient, there's a 30% conversion rate, and about 5% of these needle sticks will go on to become chronic carriers. Fortunately, there's now a very effective vaccine that will prevent conversion in the greatest majority of cases. As a point of reference, in the 1980s, there were about 250,000 cases per year of hepatitis in the U.S. By 2010, this number had dropped down to approximately 3,300, which represents a 99% decrease in cases. This is entirely due to effective blood bank testing and the presence of a very effective vaccine. If an unvaccinated person does come into close contact with a hepatitis B positive patient, hepatitis B immune globulin is available for post-exposure prophylaxis. Hepatitis C remains a very important clinical problem. Since there's excellent blood bank testing available, in-hospital transmission to patients is now exceedingly rare. But healthcare workers remain at significant risk because there is no vaccine. There's approximately a 2% conversion rate from a needle stick, and most people who convert remain asymptomatic. In other words, they never get overt signs of hepatitis. But the majority of these people become chronic carriers, and they may go on to develop cirrhosis. There are several antiviral agents that may successfully eradicate chronic hepatitis C infection, but these agents will do nothing for established cirrhosis. In the U.S. transplant centers, hepatitis C cirrhosis is either the first or second most common indication for liver transplant. Human immunodeficiency virus, or HIV, is an RNA retrovirus that binds to the CD4 receptor on T helper cells. Once inside the T helper cell, reverse transcriptase synthesizes DNA that's complementary to the viral RNA. This DNA then gets incorporated into the host cell's DNA, which leads to a lifelong infection. Ultimately, this infection leads to a T helper cell deficiency. And once the T helper cell count drops below 200, there's a sharp drop-off in cell-mediated immunity and a greatly increased risk of opportunistic infections. At this point, we say that the patient has AIDS, or acquired immune deficiency syndrome. There is no cure and no vaccine for HIV, but very effective antiviral therapy does exist, and this converts HIV infection to a chronic but non-fatal disease. Blood bank screening has effectively eliminated in-hospital transmission from transfusions. For healthcare workers, there's about a 1 in 300% chance of conversion after a needle stick. But since it takes up to 6 months to develop HIV antibodies, it will take that period of time before you know whether you've converted or not. If the source patient is known to be HIV positive, then effective post-exposure prophylaxis protocols exist. If the patient is HIV negative or has unknown status, then post-exposure prophylaxis will need to be decided on a case-by-case basis. As far as doing surgery on HIV-positive patients, Surgeons just need to take common sense precautions to protect themselves and their team. As far as the patients go, they require no special preoperative preparation, and we use the same prophylactic antibiotics as we would in a non-HIV positive patient. HIV positive patients have no problems with wound healing, and they don't have a higher rate of postoperative infections either. We'll finish up this talk by discussing two common problems on a surgical service: wound infections and central line infections. Surgical wounds are classified as clean, clean contaminated, contaminated, or dirty. This system predicts infection rates and helps guide the use of prophylactic antibiotics. For a wound to be considered clean, it must meet several criteria. The wound has to be non-traumatic in nature, and it can't be in an infected field. The respiratory, alimentary, GU, and oropharyngeal tracts can't be entered as well. Lastly, the wound must be primarily closed and left undrained. If these criteria are met, the infection rate is less than 3%. Some common examples on a surgery service include elective hernia repairs, breast biopsies, lumpectomies, and skin cancer excisions. There are several criteria for a case to be considered a clean contaminated case. The first is if the GI, respiratory, or GU tracts are entered under controlled conditions. So some examples of these types of cases would be an elective laparoscopic cholecystectomy, an elective gastric resection, a lung resection, or a hysterectomy. We're going to consider prepped colon cases in their own separate category, and we'll talk about those next. Another type of case is a mastectomy or a lymph node dissection. These would seemingly be clean cases, but since we routinely place drains, the presence of the drain increases the risk of infection. So these types of cases are considered clean contaminated. Sometimes we'll also have an unplanned minor break in technique, like an enterotomy that's quickly noticed and repaired. This will upstage the case to a clean contaminated case as well. Because there's a variety of different cases that fulfill the clean contaminated criteria, the infection rate varies quite a bit, from a low of just over 2% to a high of just below 8%. Some wound classification systems put elective colon resections into their own subcategory of clean contaminated cases. The reason to do this is even in spite of adequate bowel prep, these patients have an infection rate that might be as high as 14%, which is substantially higher than the other clean contaminated cases that we've talked about. There are several criteria for a wound to be considered contaminated. This would be any open and fresh traumatic wound, or any case where there's gross GI tract spillage. Gallbladder surgery, where there's infected bile, is another example, and any incision through inflamed but non-purulent tissue would also make the case a contaminated case. Lastly, any penetrating abdominal trauma fulfills this criteria as well. The infection rate in these cases varies from a low of about 6% to a high of 15%. The last wound category is dirty wounds. Some examples of these type of cases include perforated viscous cases, like a perforated ulcer or a perforated diverticulitis. Any kind of abscess drainage would be a dirty case, as would debridement of a necrotizing soft tissue infection. The wound infection rate in these types of cases is prohibitively high, and so these wounds are almost never closed primarily. We usually leave them open to heal by secondary intention. Preventing surgical site infections is of great importance to surgeons. Surgical site infections are associated with increased morbidity and even increased mortality, and they also greatly increase patient dissatisfaction with their overall surgical experience. Surgical site infections increase cost to the healthcare system, and in the United States, many payers are refusing to pay doctors and hospitals for the treatment of wound infections. This is under the theory that these are entirely preventable complications. In the U.S., hospitals must report surgical site infections that occur within 30 days of the procedure or within 90 days if a prosthetic material has been implanted. Adequate patient preparation is important to reduce the incidence of wound infections before elective cases. Diabetic patients need to have their blood sugars under good control before proceeding. Any patient who presents for an elective colectomy needs to undergo an adequate bowel prep. Surgery should be postponed until any remote site infections are cleared up. It's customary and traditional to ask our patients to take a shower the night before surgery with an antiseptic soap, but it's actually unclear whether this reduces the incidence of wound infections. We also traditionally remove hair from the incision site in the operating room. This should be done with clippers. The use of razors actually increases the incidence of wound infections. And finally, the skin needs to be prepped with a povidone iodine or chlorhexidine solution. The modern operating room is designed to minimize contamination from the outside environment. Air filtration systems reduce the size and number of dust particles floating around. Operating rooms are positive pressure environments so that when a door is opened, unfiltered air doesn't rush into the operating room. Orthopedic surgeons who are implanting prosthetic joints usually work in laminar flow rooms. Surgical technique is vitally important to reduce the incidence of wound infections. The presence of blood, necrotic tissue, and suture material all reduce the numbers of bacteria necessary to cause an infection. And so attention to detail is really important here. We also need to use good judgment regarding the use of drains, and we need to decide carefully how we're going to close the wound, and even whether it should be closed at all. Lastly, we need to work very closely with our anesthesia colleagues, because the presence of hypoxia and hypothermia increase all manner of complications, including wound complications. Prophylactic antibiotics are an important part of wound infection prevention, but they don't make up for poor technique and bad judgment. In general, a clean case does not require the use of prophylactic antibiotics. However, we make exceptions for clean cases that use a prosthetic material like mesh or an orthopedic implant, because in this situation, the development of an infection can be devastating. Every clean contaminated case should have prophylactic antibiotics. Antibiotics are certainly used in contaminated and dirty cases, but in these type of surgeries, antibiotic usage is considered to be therapeutic and not prophylactic. There are now specific protocols in place that help us decide what antibiotic to use. The antibiotic chosen must be effective against the expected pathogens, and it should be cheap and have low toxicity. For most clean cases and many clean contaminated cases, Ansaf will be a good choice since it's active against skin flora and the common gram-negative rods. Cefoxitin is a second-generation cephalosporin that has very good coverage against gram-negative rods and Bacteroides species, so it's a good choice for colon surgery and appendectomies. If a patient has a documented penicillin allergy, then vancomycin or clindamycin could be substituted for Ancef, and levaquin and Flagyl is a good substitute for cefoxitin. Most prophylactic antibiotics should be given within 1 hour before the incision. An exception is made for vancomycin, which can be given within 2 hours of incision time. Ancef, vancomycin, and gentamicin all require weight-based dosing. Ancef in particular has a fairly short half-life, and so if the case is going to take longer than 4 hours, it will need to be redosed. All prophylactic antibiotics should be discontinued within 24 hours. If a patient does develop a wound infection, the primary treatment consists of opening the wound, debriding it, and then packing it. Antibiotics only play an adjunctive role, and they should be used only if cellulitis, fever, or an increased white blood cell count is present. Once the infection has been brought under control, the use of a wound vac can greatly facilitate the closure of a large, complex, open wound. Let's finish up by saying a few words about central line infections. Central line infections are another major source of patient morbidity and mortality, and they also greatly increase the cost of taking care of the patient. There are a number of steps we can take to minimize the infection risk. We need to approach central line insertion just like we would a surgical procedure. And so even if the line is being placed in the emergency room or the ICU, we need to go through all the necessary steps. We need to wash our hands and gown and glove up appropriately. The patient needs to be widely draped, and the skin needs to be prepped with chlorhexidine. The subclavian vein approach has the lowest infection rate, the internal jugular vein approach the next lowest, and the femoral vein has the highest infection rate. And so we should reserve the femoral vein central line only for emergency cases. Antibiotic impregnated catheters do seem to have lower infection rates, and so if the catheter needs to be left in place for more than 5 days, we should try to use one of these devices. Multi-lumen catheters have higher infection rates than single-lumen catheters, and so we should ask ourselves whether the patient really needs the traditional triple-lumen catheter or whether they could make do with a single-lumen device. Many hospitals nowadays have dedicated catheter care teams that do the dressing changes, and this seems to result in fewer infections. Of course, one of the major things we can do is remove the line when it is no longer necessary. Central lines should not be left in place as a convenience. If our peripheral IV will now do the job, the central line should be removed. Routine scheduled central line replacement is generally not recommended. An exception is made for burn and transplant patients, however. On these units, lines are often changed on a 3 to 5 day cycle. If any patient does need a new central line, it should be inserted at a new site. Rewiring an existing line is associated with higher infection risks and should almost never be done. The diagnosis of a central line infection is surprisingly difficult to make and requires a high index of suspicion. We're rarely going to see pus or inflammation around the insertion site. Most patients with central line infections have fevers, but patients with central lines often have many reasons to have a fever, and so this is an insensitive sign. If there's a moderate suspicion for a central line infection, then blood cultures should be obtained through the line and at a peripheral site. If the index of suspicion for a line infection is very high, then the line should be removed, the tip cultured as well. The definitive diagnosis of a central line infection requires that both the tip and a peripheral blood culture grow the same organism. Most central line infections are caused by Staph aureus and Staph epidermidis. Candida is also a frequent cause in debilitated and long-term ICU patients. The treatment of central line infections requires both antibiotics and line removal. Empiric antibiotics are required while awaiting culture results because most patients have systemic signs of infection. Vancomycin will almost always be one of the drugs chosen since it's active against MRSA and Staph epidermidis. You will also need to decide whether you need to cover for Candida and Pseudomonads while you're awaiting the culture results. Catheter removal can be considered source control for central line infections and is virtually always going to be necessary. In some rare cases, particularly in patients who are access nightmares, the line can try to be salvaged by instilling antibiotics in the catheter and long-term use of systemic antibiotics. But in reality, this is rarely successful. Here's a list of the sources that I used to put together this talk. The URL for this course's website is shown here, as well as a few links to some of my other talks on basic surgical care. Thanks again for your attention.